Welcome everyone to this e-seminar on anemia management in chronic kidney disease patients. I'm Professor Jonathan Barratt from the UK, and I'm really looking forward to this seminar. We've got three excellent panelists, and I'd like to just introduce them quickly before we get started. So the first is Loreto Gesualdo.
Good evening, Jonathan. Good evening, everybody.
Lucia.
Hello, everybody. Good evening, and welcome to the webinar.
And Jan.
Yeah, hello everybody. My name is Galle, and I'm greeting you from the city of Lüdenscheid in the western part of Germany. Enjoy the meeting.
Thank you. So you can see we've got an expert panel, and we're going to start with a presentation by Tino Gesualdo, and then we're going to follow up with a panel discussion and then deal with questions that you may have of the panelists that come up during the presentation. So please feel free to jot down as many questions as you like in the chat, and we will hopefully get through most of those in the hour that we've got allotted. So now I'm going to hand over to Tino for his presentation, and I'm really looking forward to this. So thank you, Tino.
Thank you, Jonathan. Good evening, everybody again. And I will try to cover this topic, the burden of anemia in CKD patient and the unmet needs. I would like, to start, define chronic kidney disease that, as you know, is a social problem that involves not only nephrologists, but particularly general practitioners and several specialists. As we know, is a progressive disease that is often linked to risk factors such as diabetes and hypertension. Unfortunately, there is a low awareness, and we needed to increase early diagnosis, because doing an early diagnosis allow us to an adequate management of the disease in order to slow down its evolution toward the more advanced stages. Now, we know very well that CKD is very common, a silent disease, is a killer disease because it's harmful. There is, in high cardiovascular risk, but today is also a treatable disease. And this is a very good news for us. But let's start with how common is CKD. Well, the problem is alarming because 850 million people worldwide have kidney disease, more women than men. And as you can see, one kidney disease, chronic kidney disease is one of the leading chronic non-communicable disease that its frequency is higher than diabetes mellitus that counts only 422 million people against the 850 million of people affected by CKD. Big numbers for both disease, but the kidney disease are getting the flag. The numbers are due to the causes that can induce chronic kidney disease. Particularly, I would like, to remind you, diabetes and hypertension, but don't forget also glomerulonephritis and cystic disease. Well, what is the problem? Awareness. And we are missing the early diagnosis, because if we can count from an epidemiological point of view, 850 million of people affected by CKD worldwide, we know only 10% of them. We are missing the other 90%. So there is an unmet need. We need a very strong alliance with our GPs, because we needed to detect early the disease. Now, if we stratify CKD following the KDIGO CKD classification, as you can see in this slide, the CKD prevalence by stage, you can find is more frequent that we find in the stage 3, 7.6%, while stage 1 is counting 3.5%, stage 2, 3.9%, only 0.4% in stage 4 and 0.1% in stage 5. Why these numbers? We are losing our patient in this stage. They are dying in the stroke unit, and they are dying in the heart unit because they have a high cardiovascular risk. So the majority of our patients should be intercepted at stage 3. But if we are really good in doing awareness and early diagnosis, maybe we can detect also stage 1 and stage 2. So very common disease, but it's also a very harmful disease. Yes, because CKD is a killer disease. Is a public health priority because CKD as a premature cardiovascular disease with a high cardiovascular risk profile. Now, cardiorenal risk due to CKD is independent because from a meta-analysis that was performed in more than 1 million subjects, it was independent from hypertension, was independent from the presence or absence of diabetes, and was independent regardless of age across a wide range of population. But what should alarming us is that CKD was a leading cause of death in the 2016 among the more, the 20 more frequent causes. Chronic kidney disease, as you can see in these slides, was placed on the 16th place. But if we project, to the Linge coast to the 2040, as you can appreciate in the slides, it will jump from the place 16 to place 5. So it's time that we should act. It's time that we should, put in place strategies to reduce this mortality, because as you can see in these slides, 50% of our patients, we lost almost 50% of our patients died in the first 5 years of dialysis. And the mortality, as you can appreciate, is higher than colon rectum cancer, kidney cancer, Hodgkin lymphoma, prostate cancer. Now, we know very well, if we look the rate of cardiovascular events, they increase with the reduction of estimated GFR. Lower is the GFR, higher is the cardiovascular risk. So CKD is a multiplier of cardiovascular disease. This is a very famous paper on New England that saw as a first author Dr. Go. Among the complication that can increase cardiovascular risk in CKD, we found many complications. Among them, anemia. As you can appreciate, the percentage of anemia increase with the reduction of GFR. Is jumping from G2 stage to stage G3A from 5%, around 5% to 12.3%. And if we move down to G3B stage, 22.7% of patients that are report as a complication anemia. And when we get the GFR less than 30, more than 50% of our patients report anemia complication and symptoms related to anemia. Now, as I was reporting since the beginning, CKD is common, is a killer disease, but today is also a treatable disease. Many, after 25 years, 30 years, nephrology is facing a new era. We have a very rich pipeline and new drugs are coming in, and maybe will change the natural history of these very common silent and killer diseases. So let's talk regarding treatment. But before we go to treatment, let's make some comments of this slide. Anemia management in non-dialysis chronic kidney disease patient. This is a multi-center prospective study in Italian renal clinics. The first author was Professor Minutolo. This is a prospective study evaluating anemia management in 755 CKD G3BGA G5 patient followed in 19 Italian nephrology clinics. As you can see, patients affected by severe anemia lack an ASA prescription despite anemia. So this is what we call therapeutic inertia that range from 40% to 34%. So it's time that we give a wake-up call to the nephrologist, let them understand that we undertreat our patient. Why? Because there is an hyperresponsiveness, there is a resistance to ASA, or is a real therapeutic inertia. Now, if we see the burden of anemia in chronic kidney disease, we can list many items. Anemia is common in patients with chronic kidney disease and has been associated with increased risk of cardiovascular morbidity and mortality in observational studies, as well as decreased patient quality of life and increased healthcare utilization. The high prevalence of anemia in CKD represents an important clinical and economic healthcare burden. Patients with moderate CKD and severe anemia, HB around 9 grams per deciliter, generally require increased hospitalization compared with those without severe anemia. And in the US, patients with anemia of CKD have estimated a total healthcare cost of US dollars of between $3,800, $4,800 per patient per month. Early treatment costs among US patients with CKD are estimated to be more than threefold higher in patients with anemia than in those without anemia. So we should also look to sustainability. And if we see a real-world impact of cardiovascular disease anemia on quality of life and productivity in patients with non-dialysis dependent chronic kidney disease, there is this paper that comes from Dr. Kovic from 1,993 CKD patients. The main results of the paper were that patients with anemia had a higher mean number of cardiovascular comorbidity than non-anemic patients. And the presence of cardiovascular condition was associated with a significantly reduced quality of life and work productivity and activity impairment, particularly among anemic patients. And the conclusion of the paper were that the presence of anemia in this cohort on non-dialyzed CKD patients was very high, more than 50%, well, actually more than 60%. The presence of concomitant cardiovascular condition was more common in non-dialysis CKD patients with comorbid anemia and was associated with reduced quality of life and work productivity outcomes. So it's time now to move on treatment. What we know, what is our standard of care. In the opinion on the work or the working group in dialysis and non-dialysis patients from the KDIGO guidelines anemia in CKD, well, in a dialysis and non-dialysis patient with CKD receiving ASA therapy, the selected HB targets should generally be between 11 and 12 grams per deciliter. But if we analyze this triangle, this is our patient, and these are on the left, we have the iron, on the right, we have the ASA. So first, we should look at the iron status, assessing iron status. Available iron is more important than the stored iron. So what is also important that come from, the first, evaluation, that we should use the lowest possible iron dose to prevent iron overload. So we needed to individualize anemia management to reduce HB variability. And remember that using IV iron during ASA therapy to prevent iron deficiency may induce reactive thrombocytosis. So be careful. And remember to balance potential benefits of reducing blood transfusion and anemia-related symptoms against the risk of harm. So very important if we move from iron to ASA is to assess causes for ASA hyperresponsiveness, such as inadequate dialysis, occult bleeding, and particularly inflammation. As you know, CKD is by definition is an inflamed patient. Moreover, please try to use the lowest possible ASA dose to achieve the HB target. So what is the current standard of care today? Current treatment option for anemia include oral or IV iron, ASAs, and RBC transfusion, red blood cell transfusion. Now we know that ASAs increase hemoglobin levels, reduce transfusion requirements, and have been the standard of treatment for anemia in patients with chronic kidney disease since 1989. I was a fellow at that time, long time ago, Jonathan. All ASAs require parental administration. Many safety concerns have emerged regarding the use of ASAs, including an increased occurrence of cardiovascular events, vascular access thrombosis, and cancer-associated mortality. So if we see the measure published randomized clinical trials of anemia therapy and cardiovascular outcome in CKD, as you can see, they were very late. So we started to prescribe ASA when we didn't have phase 2, phase 3, and phase 4 trials. They were done later. And as you can appreciate, there was the NHS, the CCT trial, the CREATE trial, the QUIRE, and the TREAT that was done the end in the 2009, November 2009. And unfortunately, we didn't get benefits in survival from normalization of HB levels. So we were trying, to push to the higher level, but we didn't get benefits while we were getting side effects. Why this? Was the HB level or was the resistant to ASA? Was the increased doses? So there are, still many questions that are open. So question for you is, what are the appropriate target level for the correction of anemia? And fortunately, we have a very strong panelist today, Jan and Lucia. So I would like, to acknowledge Lucia. This paper was, published on 2021. She was saying, well, no benefits in survival from normalization of HB levels. And then they were reporting that NHB target range of 11.5, 12 grams per deciliter seems reasonable, even slightly less inflamed older patients. So watch to frailty in our CKD patient. And their conclusion were that potential risk associated with higher ASA doses that become a surrogate of ASA resistance should be carefully considered. So this is an unmet need that we needed to cover. But let's go back, to these slides, the percentage. We have many patients that develop anemia when they get, stage 3B and particularly stage 4 and stage 5, since, the pre-dialysis stage. And this is the history of the anemia treatment in CKD. Between the 50s and the 80s, we were doing transfusion because we were getting erythropoietin deficiency. And after we got, and in the early 90s, the ASAs on board of our treatment, so we were looking at the functional iron deficiency. But remember that you can have, problems with hypertension, with fistula thrombosis, with cardiovascular and cerebrovascular events. So now another age is opening up, and actually we are now looking at the absolute iron deficiency, and we are getting on board new kids on the blocks that are, the IF inhibitor since 2018. And these three scientists, Dr. Kellin, Dr. Ratcliffe, and Dr. Semenza, were assigned by a Nobel Prize in 2000 2019. They discovered the IF inhibitors. So, but let's see what are these inhibitors. Are a new class of drugs for the treatment of anemia. They differentiate from ESAs since they do not directly activate the erythropoietin receptor, but rather stimulate the production of endogenous erythropoietin from the kidney and to a lesser extent from the liver. Moreover, they have the beauty that they can be administered orally and not parenterally. So, but this is a very, good comments that Dr. Adira Levin reported on New England Journal of Medicine. This was an editorial, Therapy for Anemia and Chronic Kidney Disease, that was published in April 2021. New intervention and new question. Given the concern about harms with ESAs, the discovery and development of a newer class of agent to treat anemia, such as hypoxia-inducible factors, if proline hydroxylase inhibitors, is exciting. This oral agent may increase patient comfort and adherence to treatment, especially among patients receiving subcutaneously ESA injection. So these agents, as you can see in this cartoon, work by stabilizing the IF complex, by inhibiting the prolyl hydroxylase. And as you can see, the IF complex is represented by 3 different chains, 1 alpha, 2 alpha, and 3 alpha, that when they stabilize, they translocate to the nucleus and they are able to stimulate a complete erythropoiesis. They increase the release of erythropoietin, they increase the aporeceptor, but they are also able to work on the iron pathway, increasing transferrin receptor, ceruloplasmin, and more importantly, is working on the inflammation because they are able to downregulate the expression of hepcidin. So if inhibitors are able to stimulate endogenous erythropoietin production, even in patients with end-stage kidney disease, they can improve iron mobilization to the bone marrow, and they can be administered orally. So this is, the complete erythropoiesis process that goes from the gut to the liver to the bone marrow. So, but what are these stabilizers? We know right now 4 different IF proline hydroxylase inhibitor: Roxa, Vada, Dapro, and Molidustat. As you can see, they have a different dose frequency, and also they have a different selectivity on IF. For example, Roxa, Dapro, and Molidustat works better on both IF 1 alpha and IF 2 alpha, while Vada is more selective for IF 2 alpha, where the Roxa was already approved in Japan in 2019, but all the other ones have completed the phase 3 clinical trials, and we have now got it also on board with phase 3 clinical trials, also the Molidustat. And they were developed for dialysis and non-dialysis patients, for correction and for maintenance. So, in conclusion, IF inhibitors are new drugs under clinical evaluation. The availability of data suggests that they are efficacious and safe alternatives to ESA for the treatment of anemia in non-dialysis and dialysis CKD patients with severe potential advantages over current therapies. However, more data are required regarding their long-term safety and their possible non-erythropoietic effects. And with this, I thank you all for your attention.
Thank you, Tino. That was a fantastic summary of the challenges we face managing anemia of CKD and the potential exciting opportunities there are on the horizon. And what I would like is for Jan and Lucia to really comment on what they've heard and perhaps ask you some questions about what you've presented and your thoughts on how this is integrated into current clinical practice. So I'm going to ask Jan first if he's prepared to make some comments,
Okay.
and perhaps ask Tino some questions.
Yeah, thank you, Jonathan. And first of all, also would like to congratulate Tino for this great talk. You set the stage. I think what you pointed out is that there is, after many years of treatment of renal anemia with the ESAs and with iron, that there is still an unmet medical need. And that is that we have no data which show us that with the ESAs, the conventional ESAs, we are able to reduce mortality. The opposite is the case, as you pointed out with these trials you mentioned, the TREE trial, the last one in this section. And you pointed out that there are side effects we do not want to see. You pointed out that there is a resistance to the ESAs under certain conditions, particular inflammation, and that we also have difficulties with iron utilization, also in the setting of inflammation. And so there is hope that this could be overcome with the HIF stabilizers. At least that was my perspective when I followed the poster discussions during the last years, as we had the drugs not yet available. I was very interested, particularly in this point, that HIF stabilizers could overcome the problem with resistance to ESAs because they improve iron utilization, they reduce hepcidin. So these are some pathophysiological effects which could be, in a positive way, be influenced by the HIF stabilizers. So that was the hope. And where are we now? I think the situation has not become very easy during the last years. And I think this is also reflected by the worldwide situation concerning where are the drugs available or not. It seems to be quite simple in Asia, in India and China. More than just one substance of those you mentioned, staprostat, vadadustat, and roxadustat are available. But in Europe, at least in Germany, we have only roxadustat available. I know that vadadustat is trying to get a label, but they have not yet succeeded. And in the United States, the situation is also complicated. So there were some safety issues raised, which particularly were concerning the use of vadadustat. So it is not that simple. So it's not clear to say, okay, we have now the HIF stabilizers. And since we have them, all the problems I mentioned with the unmet medical need concerning the conventional ASAs has been overcome. And also we have the situation that there is not a lot of experience so far. In Germany, for example, we have one drug, the roxadustat, available since now, I think it's 15 months or 16 months, but still there is not so much experience because the label in Germany is quite complicated. I'm curious to hear from you, Jonathan, how the label in Great Britain is written. In Germany, it says, well, if there is a patient stable on a conventional ESA, he should not be switched to roxadustat. Only if you have particular reasons. That could be either hyperresponsiveness, maybe due to inflammation, then you may consider to switch the patient to roxadustat. But so, I mean, you can use it, but it's not that simple. And so there's still, I would say, some sort of hesitance of most nephrologists in Germany to use the drug. And that's why we have not so much experience. Myself, I treated some 5 patients with it so far, but it's not as much. And German doctors anyway are quite conservative when it comes to new drugs. If you have something which you know for now, I think it's 30 years, a little bit more, since we have them conventionally available. So there are hopes, but there are still many unanswered questions. And one point I would like to raise and to point out, Tino, you said that it's a nice thing to have these drugs as a tablet. And I'm not totally convinced that this is really an advantage. One at least has to discuss it, because renal patients have already a huge tablet load. And if you increase this by 3 times a week a tablet, or every day, concerning which drug you use, this adds to the amount of tablets you already have. And then you may also ask the question, is it really better to be responsible to have your tablet or get an injection once every 2 or once every 4 weeks? For me, that's not so clear whether it's really a benefit. And this concerns now the patients who are not yet on dialysis. For the patients who are on dialysis, it's quite simple. They get the drug injected without having to use the subcutaneous lining. So the nurses usually do it, and then you can be sure that the patient really has got the drug. On the other side, which is a new discussion, at least in my country, there are also environmental issues to be considered, because it really could be a big advantage that you don't need refrigerators anymore with all the costs they generate. And then final point concerning the environmental issues, I wonder how much energy you need to produce a tablet, the HIF stabilizers, in comparison to bioengineering and conventional erythropoietin. So there's also difference. So many issues, and I will finish at this point because I raised some questions more than I did answer. But Jonathan, I hope that was what you intended to induce.
Well,
that's fantastic. So I'm going to let Tino respond before we move on to Lucia.
Well, thank you, Jonathan. Well, Jan was a very challenging. You are right. There are, two points well taken. The first one, the overload of tablets for our, patient is more, and we needed, to differentiate patient on dialysis from patient not on dialysis. So, but I think that for this, to answer to this question, if they prefer tablets of injection in non-DD CKD stage, we needed, to apply prompts, how, the patient think regarding their therapy. I agree with you that they sometimes, they complain regarding numbers, but there are also patients that complain regarding injection. So we needed, a trial, like, or maybe a real life approach, to let, the patient answer to us regarding what they think regarding tablets versus injection. Regarding the second point, sustainability, and particularly the green part, I think that this is a very good, well taken point, because I think that we have not considered it in the past, because also you needed, the fridge, but you needed also to discard the syringe. Don't forget. So you needed. So there are, many questions on the table that, Jonathan, I have very well taken, I think.
Yeah, no, it's really interesting because we've not had the green angle before, but there is a lot of disposable waste that are generated through both tablets and injectables, probably more with injectables, but it is a really important point. And now, Lucia, coming to you and your thoughts on the matter.
Yeah, well, I think that Loreto Gesualdo made a wonderful overview of the epidemiologic part of anemia. And he clearly underlined that the number of patients affected is huge. And we are not somehow, we know that despite experience with ESA of more than now 30 years, we are far from being completely satisfied, because these drugs are definitely effective in many patients. We are, used to prescribe them and modify treatments in our patients. But in the last 15 years, it has become clear that their safety is not optimal, and we are still debating which is the best hemoglobin target to aim at, because we know that, we are staying at partial correction, but in real life, many physicians stay much, much lower. This implies that anemia treatment is suboptimal in many patients, especially in non-dialysis patients, with a lot of treatment inertia. So many people are not started erythropoiesis ESAs and often are not given iron. And this can somehow put patients at risk from, let's say, cardiovascular function, but also reduce a lot their quality of life. And so in this perspective, I think that we as the nephrologists put great hope in these new drugs, also because their mechanism of action is unique. And I mean, from the scientific point of view, I consider them fascinating because they enter and affect not only anemia pathways, but many other aspects. And yes, unfortunately, expectations were much more than what in the end we obtained from these large phase 3 clinical trials. And so I think we have to find or understand better how to use them now in real life, given that at least roxadustat is entering many countries or has already entered. And I think the problem is some safety issues that come out from phase 3 studies, especially for vadadustat in non-dialysis patients. And this certainly has somehow reduced the potential of using this drug. But I think, especially in non-dialysis patients, the fact that they can administer it orally are of great interest, because many patients definitely prefer the oral administration. And so I would like to Tino to make a comment of also on the aspect of quality of life. If he does do things that it's important for the patient, and if these drugs, do you think that they can somehow improve quality of life in comparison to ESA, or they simply increase hemoglobin and that's it?
Well, Lucia, thank you very much for this question. I think that, you know, we should move in from prescribing to listening our patient. And, you know, now, you know, is on fashion what we call prompts. So what, you know, the drug really does in our patient. The quality of life, I think, is a topic that should be covered by us. We maybe should ask more often to our patient, how do you feel today? What are your problems? So I don't think that is a matter of HB level, but how, you know, you feel with that HB level. So, and we should also be carefully when we use, you know, high dose of ESA, because that is, as I was reporting also on my lecture, there's a surrogate of hyporesistance. So there is something going on, especially, you know, inflammation that we should cover. So quality of life, I think, is a topic that deserves a design trial. So we need, you know, to think about it, to think how our patients are feeling. But we also needed to reflect on an important point that you were raising, that is inertia. You know, inertia is unbelievable high among us. And I don't understand why we don't believe it in anemia treatment, or why is happening. So this is a question for both of you. How do you explain inertia? How do you explain the lack of awareness on anemia treatment? Why is happening?
If I can give you an answer, or at least my opinion, there are 3 different aspects influencing this inertia. First, a lot of physicians are, I mean, too pressed when they're making their outpatient visit, and time are so strict. And at least in Italy, we have to apply for administrative processes to prescribe ESAs. And sometimes you say, well, this time is over. It's not right, but many physicians think like that. The time is over. Well, the anemia is not so low, so let's wait to the next appointment to prescribe ESA. And this is the first point. The second point, I think, is that sorry, I lost my point. The second point is probably the influence of the guideline we have at the moment, KDIGO and ERBP, that suggest recommendation mostly on the basis of the TREAT studies. And we have to remember that the design of the TREAT study compared high hemoglobin target with darbepoetin alpha in comparison to placebo, without finding a difference on cardiovascular endpoints. And I think this is probably one of the main reasons, because we know that the target that was used for comparison was a complete anemia correction. So we do not have any data on partial anemia correction in comparison to low hemoglobin level. And also, we also know that patients who were randomized to placebo, as a matter of fact, were not kept really at 9 grams per deciliter, but the majority of them remained between 10 and 11, and many of them received erythropoietin. So we have the result of the primary analysis saying patients were left with placebo at 9 grams per deciliter, but this was not the real course of the study. I think that this data have a great burden on the decision of physician to start erythropoietin in non-dialysis patients.
Thanks, Lucia. And Jan, what in terms of Germany, what is there this inertia, and what are your thoughts about that?
Well, you could call me also, or you could accuse me a doctor with inertia. I give you a typical example of my patients. Let's take any patients with a GFR around 30. I check them usually every 4 months. So they come to my outpatient clinic, I take blood, I measure the transferrin saturation, I measure the hemoglobin, and I measure the renal function factors. So I see, okay, GFR 30, and let's say this patient has now a hemoglobin of 11.2, and the iron saturation is still sufficient, at least above 20. So I will not take any action at that point. And I know my patients for a long time, and he comes back the next 4 months, and maybe the hemoglobin has dropped a little bit. So I focus on it, but I still take no action. And then something happens to the patient. He gets a pneumonia, or he has a fracture, or anything. He comes to a hospital, and then this formerly stable patient drops down with his hemoglobin. If you would check on him then you would say, okay, Professor Galle can be accused of inertia. So I think we have the situation that our patients may be stable for a long time, but then they suddenly drop because some clinical event takes place. And maybe this leads to some sort of overestimation of what Tino called inertia. We have that, we have that fact too, that we can see patients who in the retrospective, one would say, should have been treated, but maybe they had just dropped quite sudden because of any clinical event. This at least contributes to inertia, I would say.
So I think there is, I take your point, I think there's a very fine line, isn't there, between inertia and taking an incredibly personalized approach to the patient in front of you. So for me, if it's a 20-year-old young man who works on a building site, who's starting to symptomatically get unwell with anemia, who's got CKD, I'm going to have a lower threshold to intervene. If it's someone who's older and more sedentary and actually doesn't have any symptoms, but biochemically has a hemoglobin that would warrant some intervention, I may or may not intervene because I'm thinking, am I going to improve that quality of life? So we do take a very individualized approach, which for me, I think is a good thing. But when you look at it as a population, it can look like we're not doing the right thing for everyone. But a guideline is only a guideline at the end of the day, isn't it? And we need to, I'm a very strong advocate for individualizing the approach to the patient sat in front of me. And that leads on quite nicely to some questions that we've had. And one of the questions is, and I'd like everyone's opinion here, is with the new class of drug, with HIF stabilizers, do we need to rethink how we approach renal anemia? Do we need to rethink the threshold that we might want to start an agent like a HIF stabilizer? Do we need to rethink the targets that we want to achieve? Do we need to rethink how we monitor those patients? Because that's a common question that lots of people are asking. So I'll come to you, Tino, first. How are you altering your approach, or are you altering it at all if you're going to use a HIF stabilizer rather than an ESA?
Well, actually, this is a very good question, Jonathan. And actually, I'm taking also a question from the floor, because there is Dr. Ramadan that is reporting, is declining of HB with ACE inhibitor or rising HB with SGLT2 inhibitor clinically significant? So we are introducing in our clinical practice, in our treatment of CKD patient, new drugs, and among these, the SGLT2 inhibitors and the stabilizer. So I think that we needed to rethink, because we were doing, blood transfusion before the 90. And after we were using ESA, and we were only, pushing on ESA because, was, a synthetic molecules that we were building in the biological, biodrug that we were producing and injecting to our patient. Now the stabilizer are coming in. Stabilizer, as I show in the lecture, is working on the total erythropoiesis pathway. So it's targeting the erythropoietin, also in very late stage, CKD, is targeting the receptor, is targeting the iron pathway, is down-regulating inflammation. So I agree with Jan that each patient has his history, and that I think that he agreed with me that we should ask the patient, how do you feel? Do you have symptoms? So if he's stable, maybe it's better that we keep him stable and we intervene when, there is a concause that, can decrease HB level. But you got a very good point. And on the top of this, answering to Dr. Ramadan, you are right. ACE inhibitor are declining, and we are now understanding better how the SGLT2 inhibitor are working. They are, working on stabilizers, so they are also able to modulate, the response of erythropoietin and maybe also inflammation. So, well, there is there are many unmet needs, that should be covered. And you got a very good point, and maybe, new idea for, to design new clinical trial that will answer to your question. I don't know if I have covered what, you asked to me.
Thanks, Tino. And I'll come to Lucia now. In terms of your approach, will you change your approach to that patient in front of you who needs either a HIF stabilizer or an EPO? Will you do anything different?
I think it will be, it is a new option. And I fully agree with you that we need to personalize our treatment on the basis of the patients we are having in front of us. And the treatment of anemia is made by ESA, it's made by iron, is made by, targets and when to start, and it's made by patients who sometimes have different difficulties in making injections. And in patients not on dialysis, often have concomitant iron deficiency. And oral iron sometimes works, sometimes is not well tolerated. We know that in many patients, we can think about administering a large iron molecule intravenously, and it's helpful. But in everyday clinical practice, the access of intravenous iron in hospital is not often so straight. So the idea of having a third option, mixing the possibility of possibly a better iron absorption and, let's say, treating anemia more smoothly from the perspective of the patient, it's a third option. So I'm happy to consider it.
Thank you. And Jan?
Well, I tell you a short story. I'm old enough to remember very well 30 years ago when I was a trainee on a dialysis ward, and my very esteemed supervisor, my boss, came for a visit, and he looked at the records and he noticed there's a patient with a hemoglobin of 13. He really exploded. And then it took us around 15 years until we came to a conclusion which range of hemoglobin we should have with the erythropoietins. I hope it will not take another 15 years before we find out which hemoglobin target we want to see with the HIF stabilizers. But I would say at the moment, we really do not know. We start a completely new field. These drugs go into so many pathways to reach higher hemoglobin levels, of course, we would also need higher dosages of the HIF stabilizers, and we do not know what this will cause also on other pathways. Therefore, I'm still very cautious, and when I start treating my patients with these drugs, I still restrict to the targets we have now for the ESAs. Maybe in 10 years' time, we will know it's safe to go higher, and it will not increase thrombosis, apoplex whatsoever, but at the moment, we just do not know.
I completely agree with you. I think we have to work to current targets in terms of what have been established with current standard of cares, and then test whether we should do something different with the stabilizers. There's another question asking about inflammation, and inflammation is a real challenge for us, isn't it? Particularly in our dialysis patients. And Tino has mentioned many times hyperresponsiveness, and actually a large cohort of patients exist on every dialysis unit who are really not doing very well. They've got chronic inflammation, they're requiring high doses of EPO and still not really achieving the hemoglobins and have a poor quality of life. And so what are your strategies to manage those patients in terms of how do you deal with that? So Jan, we'll come to you first.
Yeah, I would like to answer this question because I stepped over a study which was published at the ASN as a poster. It was a sub-analysis of the daprodustat trials. And what was noted there was that if a patient has been hyperresponsive to an ESA, he also or she also needs higher doses of the HIF stabilizer. That was a little bit astonishing to me because I thought, okay, these are just the patients, those who are hyperresponsive due to inflammation, who might be switched to a HIF stabilizer. But then you also need higher dosages with a HIF stabilizer in these patients.
Thank you. And Lucia, your approach in terms of those really difficult to treat dialysis patients who really are having a very poor quality of life and a poor time?
But I think, well, first approach every time is to understand why one patient is hyperresistant. This is the first important point. It's true that sometimes you cannot find the cause and, let's say, treat the cause. As you said, these are very, very difficult patients because many of these patients have very high ferritin levels, but also functional iron deficiency. So you are in the situation to, let's say, to want to administer intravenous iron, but you also know that intravenous iron could be dangerous in these patients because it's not can become toxic in the circulation because not taken by deposits. And this is a major challenge. What about if PHD inhibitors in this subset of patients? Well, they have the potential of being more effective than ESA, and going to their mechanism of action, because the HIF system also regulates not only anemia, but many pathways in inflammation, and also influence many cells of the immune system. And there was data from some phase 3 studies, especially from China, from Chen and other studies there, saying that with PHD inhibitors, you can save somehow part of the dose needed to correct anemia. What is the problem? That the majority of phase 3 trials were made in patients with a low degree of inflammation. So as a matter of fact, at the moment, we have no evidence to really be sure to know yes or no, they are more effective in the let's say, the true hyperresponsive patient. I think we need to try to use them in everyday clinical practice or wait to, let's say, studies designed exactly for this purpose.
No, I think that's a really good point. You know, none of all the phase 3 trials excluded patients with active ongoing inflammation and EPO hyperresponsiveness, most of them to the kind of degree that we see. So Tino, your thoughts on EPO hyperresponsiveness in those inflamed patients?
Well, actually, this is a very, challenging topic and challenging question. As you know, Lucia was reporting, first we needed to ask to us why we are getting an EPO resistance. So we needed to differentiate an acute inflammation from a chronic inflammation. Now, so let's go on the acute. If we have, for example, a urinary tract infection, we should first treat, the infection and after start, iron as well as ISA, treatment. So on the other hand, if we don't find, acute infection going on, so we should think that the CKD, by definition, is an inflamed patient. So I think, and as you know, Lucia was underscoring, we don't have, this kind of patient in the phase 3 trial, but this is, a phenotype of patient with chronic inflammation that maybe, but we should, see real life. So we should do, we should have more clinical practice that can, have advantages in using stabilizer, because as is what is being reported in the literature, they can, modulate particularly the hepcidin. So I think that there is, space in the chronic inflammation, but chronic inflammation is not only, we needed also, to improve maybe the quality of life of our patient. Most of these patients most of the time are frailty. So maybe we needed also, to treat them with a better diet, maybe to tell them do some exercise, and let's treat also, with the right drug. So I think, Jonathan, that the next future is to phenotyping patient, to personalize, treatment, and this will be a big challenge for all of us.
Thank you, Tino. And that brings us nicely to the end of this seminar. We have a couple of minutes left. And what I wanted to do is to ask each of you to give your final thoughts, your take-home message from this. And I think I'm going to start. So I don't. I think the take-home message is this is an exciting time for the management of anemia of CKD. We have a new treatment. We have a new class of drugs. But as has been mentioned, we're going to need to learn how best to use them and which patients we are going to want to use them in. And that's going to be work that's going to evolve over the next 5 to 10 years would be my guess. So I'm going to come to you first, Tino, just for your final comments on this area and things that you think might be useful to think about in the future.
Well, as you said, Jonathan, we are facing a new era in the nephrological field. We have new drugs, and we have new drugs also in the anemia field. So what I would like, to suggest is, first, phenotype very well your patient. Try to understand what kind of patient is in front of you, and don't forget, try to listen in and try to collect what kind of symptoms are they reporting to you.
Thank you, Tino. And Jan?
I would like to add just to the last point of Tino and saying it's a very interesting experiment now, listening to your patient and finding out whether he prefers a drug or an injection. That's an open question to me, which I'm very interested how it will be answered in the future.
Thank you. And Lucia, for the final word.
Yeah, I've been asked several times this question. Which patient would you prescribe first CKD inhibitors? And I think this is a challenging question. And my answer is probably to the best patient I have and to the worst patient I have. In the best patient, I'm, let's say, calm and safe and say, well, probably I will not meet any difficulties and I will improve my expertise. And the worst patient, I will give him a different option.
Thank you. Thank you very much. Thank you, all three of you. It's been a fantastic hour. I've really enjoyed it, and I hope our listeners have as well.